Well, I think we should get started. I know there are people wandering around the building doing various things, and they will get here when they get here. And I want to just make a few announcements. We have a session that we're adding in about 3 weeks, I think. Yeah, but it's 28 days, so it's the 29th of March. Today's the first. Alan Morris, who is a professor of anthropology at Cape Town and a fellow here at Bill Foreman Fellow of Anthropology at Harvard, is going to give a talk here on the 29th on cultural identity, human rights in South African forensic anthropology, which is a major piece of his work. And then we will have Sarah Hodges on biotrash and Greg Mittman on ecological imperialism revisited. And then it's been proposed in the last week that we have a wrap-up session for really the 2-year cycle, particularly this year, of the CHR. So John proposed this, and we will schedule this on the 19th for a session for faculty and graduate students and anybody who's interested will go out to wrap up our 2-year cycle.
April 19th?
The April the 19th. Connected with the obvious well. Not March 19th. Okay, today we have Professor Matthew Klingle from Bowdoin College, where he works in history and environmental studies and about to be taken on the burdens of chairing the program in environmental studies.
Not for another 2 years.
Oh, another 2 years. I was thinking it was next year.
Yeah.
Fall upon your shoulders. Matt did his BA at Berkeley, PhD and MA at the University of Washington, where he studied with Richard White. Has published widely in edited volumes, the Journal of Urban History, the Journal of the West, History and Theory, and his first book, Emerald City: An Environmental History of Seattle, with he tells me today he had advice from Mance Blackburn from our department many years back, or a number of years back. Maybe not, we should use that term yet. Which came out from Yale in 2007 and won the OAH Billington Prize in Western History. So congratulations on that. Now, various emerging projects are underway, including a project on the Androscoggin River in Maine. I keep wondering if you must have read Ron Farmasawa's book about lobster wars. Farmasawa's old pal of mine. Lobsters are out there off the project. Writing reviews in labor and environmental history, consumption environmental history, and obviously engaged in a major project for which we read today, Sweet Blood. The title of his project is Environmental History of Diabetes and Chronic Disease in North America, to which I've added race for our paper today, which I think is pretty logical. And most importantly in this is a huge project, and he has the beneficiary of a 3-year Andrew Mellon Fellowship, New Directions Fellowship, which allows a certain amount of free time, I suspect, as well as funding for the research involved. Now, we're honored today to have as commentator today one of the country's, if not the world's, leading diabetes experts. Dr. Stephen Gabi, who is the Senior Vice President of Health Sciences at OSU and the CEO of the Wexner Medical Center. Dr. Gabi received his BA from Princeton, MD from Cornell, which is the first of 2, at least institutional connections. I was an undergrad at Cornell. And then went on to work in obstetrics and gynecology at the University of Southern California, University of Colorado, University of Pennsylvania, possibly overlap there too. And then joined OSU in 1987 as chair of obstetrics and gynecology. Then went off to the University of Washington, where he may have overlapped with Matt, and to Vanderbilt, and coming back to OSU in 2008. And Dr. Gabi's particular area of expertise is diabetes and pregnancy, and a quick look at the Web of Science brings up a host of synthetic articles just on the first 20. The last one dating to about a month ago, or maybe December of 12, in specifically gestational diabetes, which is clearly emerging as a major area. And as an editor of the leading textbook in obstetrics, it may well have contributed to saving the lives of a few people in the room. So I'm going to, having done introductions, I'm going to sit down and give Matt the floor, and then Matt will give Professor Gabi the floor, and then we will kind of assemble you up here if that's what you'd like to do. However you want to arrange it, it's your choice.
Thanks, Sean. Well, it's an honor to visit Ohio State, one of the world's great public universities, and a land-grant university like my own alma mater. And I want to thank John Brooke, Chris Otter, John Davis, Dan Royals, and Kara Campbell of the Center for Historical Research in particular. I'm also very grateful to Steve and Gabi. Dr. Gabi, as John has already mentioned, is one of the world experts in the etiology and pathogenesis of diabetes, particularly the complications involving pregnancy, gestational diabetes. And seeing as this is the first formal version of which was a very fledgling project, I feel very fortunate. And I also need to thank Bowdoin student and Columbus native Maya Little, who helped prepare the images for today, and despite my paper topic, urged me to try Jenny's ice cream, which I did last night. Now I'm going to keep my remarks relatively short because I'm interested in the discussion. So I'm going to jump right in, but one thing I should tell you is that this slide and the concluding slide are from the collection by Kelly West, physician at the University of Oklahoma Medical Center, and the award that's given for the most pioneering work in diabetes epidemiology is named after Dr. West, and these come from his papers. And I just thought it was a fitting tribute to a person not unlike Dr. Bennett and others to have this as part of the presentation. Now, according to the Centers for Disease Control, as of 2010, approximately 25.8 million people, or 8.3% of all Americans, are living with diabetes, and the vast majority with type 2. It does not strain hyperbole to say that at the start of the 21st century, diabetes has become an all-American affliction, although some Americans are more at risk than others. Now, there are many reasons for this dramatic surge, from extended life expectancy to improved testing, but most observers believe that obesity is one of the major driving forces. Now, this is not a new observation. For at least a century or even longer, physicians have long linked excessive body weight to what was previously known as adult and maturity onset diabetes. Now, in many cases, it's easy to blame shortcomings in human nature for obesity and its fellow traveler, diabetes. But as obesity has emerged as a specific public health concern over the past several decades, many research also suggests that larger environmental changes, perhaps in conjunction with genetics, may explain why some people get fat and develop diabetes, among other chronic diseases, as a result. Consequently, as scientific understandings of diabetes have changed, so have perceptions of who or what is to blame. Is it addictive fast food? This was a recent article in the Sunday New York Times Magazine, which some of you may have read. Or food additives like high fructose corn syrup or an older nemesis, sucrose or table sugar. Is it our car-bound suburban lifestyle? Or is it a version of Rachel Carlson's Silent Spring, a man-made chemical catastrophe? Now, as an environmental historian, I find all of this fascinating. In my first book, Emerald City, An Environmental History of Seattle, I traced how the efforts to reshape the physical landscapes in and around that iconic and putatively green city often ended not only in ecological disaster, but also social inequality. And it was this connection between environmental change and social inequality, plus deep personal and family concerns specific to diabetes in particular, that led me to my current project, in which I'm trying to rethink the history of diabetes as environmental history. But what is an environmental history of diabetes? A definition may help. Environmental history today analyzes the reciprocal and interrelated formation of the material world alongside human ideas of the world and the structures we create to exploit it. In this analysis, environment encompasses not only the physical landscapes in which human and non-human beings live, but also other activities and behaviors: diet and nutrition, exercise, the exposure to pollutants and toxicants, plus social and political and economic conditions. To paraphrase historian Greg Mittman, who you'll have the pleasure to meet in a few weeks, to see diabetes historically in this way is to see it not as a thing but a relation, a way of being in the world that changes in both place and time. That is, to see it as environmental history. Now, the paper I shared with you is a preliminary synthesis of my larger project. Over the course of the past 2 years, thanks in part to studies and research in public health and biomedical science, largely at the Harvard School of Public Health, funded by a generous fellowship from the Andrew W. Mellon Foundation, I've been able to track 3 salient questions, which are still evolving. First, how shifts in diet and nutrition, plus changes in the physical environment since the mid-19th century, may have altered chronic diseases such as diabetes. Second, how diabetes has become enmeshed within particular landscapes, communities, and bodies unequally over the past century. And third, how scientific and clinical understandings of diabetes have changed over time. In this paper, I address the last question, and only partially. And as a result, the voices in this paper are primarily those of scientists and physicians, not the native peoples who live with diabetes and its complications. I want to emphasize, however, that the story of native resilience in the face of diabetes is important and inspiring, as are the stories of all Americans of all backgrounds living with the disease. And these stories will be part of my project too. But the focus today is on the nearly 50-year prospective cohort study of the Pima or Akimel O'odham of southern Arizona and the larger context surrounding that study. The story of the Pima is now well known and popular in scientific literature alike, and is well known for good reason. Much of what we know about today about the etiology and epidemiology of diabetes, particularly type 2 and its connection to obesity, emerged in part from research carried out in conjunction with the Gila River Indian community, located near Phoenix, Arizona. Launched by the National Institutes of Health in 1965, researchers at or collaborating with the Phoenix Epidemiology and Clinical Research Branch have helped to redefine our understandings of this dread disease. Yet the Pima studies did more than help reshape scientific and clinical landscape of diabetes. They were also rooted in the very physical and cultural landscapes in which those studies took place. The initial discoveries of diabetes among the Pima seemed accidental, but it grew out of a longer history of looking for environmental explanations to chronic disease. The initial NIH research team in Arizona was part of a comparative epidemiological field study of rheumatoid arthritis, or RA, in two native communities, the Blackfeet Confederacy of Montana and the Pima of Arizona, that lived in very different climates. After discovering that nearly 1 in 3 Pima had significantly elevated postprandial blood glucose levels, the Phoenix group shifted its emphasis from studying RA to studying diabetes. Now, prior to the NIH team's arrival, however, in 1963, Arizona's environment had already yielded both sanctuaries for health seekers as well as sites for medical research. The two blurred together over the course of the early 20th century. Consumptives and asthmatics flocked to the Southwest in search of relief. Simultaneously, the region's diverse native peoples were subjects of medical study for 2 reasons at the time: observed susceptibility to infectious diseases like tuberculosis, or perceived resistance to chronic diseases like diabetes. While the discovery of diabetes among the Pima seemed inadvertent, it was predicated directly and indirectly on decades of previous research on diet, nutrition, and other environmental factors affecting American Indian health. Beginning with anthropologist Arlish Herliska's 1908 medical survey of the Southwestern Indians, other researchers soon followed. Dr. Elliot Jocelyn, the noted diabetes specialist who visited Arizona in 1940 and published his results in the Journal of the American Medical Association that year. Dr. Kelly M. West of the University of Oklahoma, who authored one of the first systematic reviews of diabetes among native peoples in the Americas. And of course, immunologist and rheumatologist Dr. Peter H. Bennett, one of the primary investigators of the NIH studies. By the late 1960s, from a research perspective, the NIH Phoenix team had an ideal research environment in which to work. Not only did they have the Pima, whom they saw as homogeneous and physically isolated, they also had the nearby resources of Arizona's burgeoning biomedical community, which by 1960 had more dedicated facilities for Native American clinical care and research than any other state in the lower 48. And the Phoenix Indian Hospital was the central node in a robust network that stretched across 4 states that promoted and circulated emerging ideas about Native susceptibility to diabetes. Those same studies added to contested debates over racial explanations for disease. Without going into the details I spell out in my paper, researchers associated with the NIH Phoenix team and those conducting similar research elsewhere advanced several theories to explain the Pima's seemingly unique susceptibility. All of these theories, from the so-called thrifty genotype hypothesis to its competitor, the thrifty phenotype hypothesis, relied in part or in whole upon environmental explanations, often in combination with genetics. These debates continue to this day as new advances like epigenetics further complicate our understandings of diabetes and its complications. Now, when it came time to honor the Pima for their contributions to biomedical science, the NIH did so by historical analogy. In a 1996 publication titled The Pima Indians, Pathfinders for Health, the authors compared the Pima's willingness to participate in the studies to their ancestors' roles as U.S. Army cavalry scouts during the Mexican-American War,
or as guides for immigrants during the California Gold Rush. Written for a popular audience, the publication highlighted how researchers continue to look for genetic answers, even as they try to account for environmental factors. But read another way, Pathfinders for Health also blurred the boundaries between biomedicine, human history, and environmental history in startling ways. The Pima were neatly folded into one of America's foundational national myths, the frontier story. They were depicted as pioneers on the advancing edge of two frontiers, the expanding 19th century American empire that tried to assimilate native peoples like the Achaemenid, and the brave new world of cutting-edge scientific research. The irony was that but for the first frontier, the Pima could not have been pathfinders for explorations to the second. At its core, the frontier metaphor is a fitting place to discuss the renewed attention to environmental explanations, often in conjunction with racial explanations for diabetes today. The transformation of the American and global diet thanks to widespread consumption of simple carbohydrates like table sugar or high fructose corn syrup has long been under investigation. Witness the recent paper published in PLOS 1 on sugar consumption and diabetes prevalence this past Thursday, and highlighted in the New York Times by the ever-present food writer Mark Bittman. So too is declining physical activity, the partial result of our modern, mechanized landscapes of convenience. But there are other explanations on other scales as well. Take, for example, the Pima. The Pima were once renowned for their agricultural prowess and self-sufficiency. With the arrival of American settler colonialism, they lost a bitter battle for the Gila River, which upstream white farmers diverted to water their crops. Despite later efforts to restore water to the Pima, the damage had been done and their agricultural economy practically evaporated by the mid-20th century. The Pima example has been used to explain diabetes and obesity among other native communities as well, such as the Fort Berthold community in North Dakota. In this framing of chronic disease, large-scale alterations to landscapes that generate ill health are a form of what University of Wisconsin scholar Rob Nixon calls slow violence, a kind of delayed destruction that is dispersed across time and space. Other researchers working on still different scales speculate that changes to our bodies as well as our landscapes are responsible for widespread obesity and the diabetes epidemic. In the early 1990s, endocrinologists began linking exposure to chemicals broadly called endocrine disruptors, including pesticides, herbicides, and plasticizers such as bisphenol A, popularly known as BPA, that mimic the function of human hormones to a host of health problems that included diabetes. While this research remains disputed, the leading professional association of hormone experts, the Endocrine Society, has publicly criticized the U.S. Food and Drug Administration for failing to ban BPA in food or study the effects of other potential endocrine-disrupting chemicals. Meanwhile, environmental justice advocates have added diabetogenic and obesogenic chemicals to their litany of concern and documentation of persistent discrimination. These new environmental explanations for diabetes underscore that the disease and its complications are what Horst Riddle and Melvin M. Weber have called a wicked problem that encompasses complex interdependencies of environmental, political, and scientific knowledge. And I'd add history to that list because, after all, historians are in the complexity business, even if we're not explicitly in the problem-solving business. Without a doubt, the studies by the NIH with the Gila River Indian community have yielded untold benefits for all Americans, native and non-native alike. Yet the emphasis on basic biomedical research and discussions about diabetes sometimes obscures the historical context that may explain why particular populations have become more susceptible to so-called diseases of civilization. Rethinking diabetes and environmental history may help us to reframe the stories we tell about this dread malady. Telling stories that are new may also in turn reorient how we address diabetes, past and present, as a disease of long-standing inequities, embodied in place and over time, in our bodies and the places we all call home.
Great.
Now I'm going to turn this off so that we don't get blinded by the light.
You just hit a B on the,
Hit B.
just hit B.
Easy. Great. Thank you.
So how do you want to,
Do you want to sit up here?
Sure. I'll
Okay.
take it for 10 minutes.
Good.
you want to get rid of this?
Thank you. It's great to be here, and I really enjoyed your paper because these are areas that I've worked in and thought about for a long time. I have to tell you a little bit about why I've devoted most of my life to taking care of people with diabetes, especially pregnant women with diabetes. It's one of these unanticipated challenges in life. I talked to the medical students about it in their first week as medical students, and I call my talk "A Glass Half Full of Lemonade," because I've always been an optimist, and I think things occur for the best. Whereas a good friend of mine said, not why did this happen to me, but why did this happen for me? So when I was a third-year medical student, I developed the classic symptoms of diabetes: polyuria, polydipsia, fatigue, weight loss, hunger. Of course, I didn't believe it. So I tested my urine, which was what we did in those days, and it was always strongly positive for glucose. And finally, after a week of denial, I had to realize that it was in fact the case that I had diabetes. I went to student health, and I told that student health I was there because I thought I had diabetes, and he said, "You must be studying diabetes this week." The students do sometimes believe they've got whatever disease they're studying. He said, patted me on the head and said, "Don't worry, we'll check you out and just come back in an hour." So I came back in an hour, and he said, "My God, you have diabetes. Your blood sugar is elevated." And then he did something which is unfortunately common among health providers who get sick. He assumed that I knew all about diabetes. And so he said, "Here, take these pills, don't eat any sugar, and check your urine." No real discussion about living with diabetes. Now, it was interesting he gave me pills because what I had was what we now call type 1 diabetes. I had what was then called juvenile diabetes. But because I was 22 or so, he assumed I had what we used to call adult onset diabetes. Juvenile form, the type 1 is treated with insulin because you don't make insulin anymore. The adult onset form is treated with pills. It's still true today. After a week or so, it was clear that I needed insulin, and so I began taking insulin, which I've done for the past 45 years. I had a very good internist, a young fellow, who said, "Stephen, we don't know whether taking really good care of your diabetes, that is trying to keep your blood glucose levels as normal as possible, is of benefit. There's no evidence to that, support that. I think it does. So I think you should try to do the best you can." Well, in those days, there were no glucose meters. There was really no way to know how you were doing because, as we all learned, testing your urine was worthless. So you really never knew. It was like driving a car without a speedometer. You didn't know how fast you were going, how high your levels were. You didn't know how low you would get because you got very symptomatic when your blood sugars were low. And because that's embarrassing, and because it's compromising, and because I was taking care of patients, it was something I really worried about a lot. So it was this constant push and pull. I was advised by my mentors that I should select a specialty that would be more predictable in terms of lifestyle, maybe radiology, pathology, but not being very practical and wanting to do what I wanted to do and what I most loved. I decided to do obstetrics and gynecology, probably the most unpredictable lifestyle. And not only that, I decided subsequently to do high-risk obstetrics, which meant that my entire career would be spent getting up in all hours of the night, taking care of pregnant women who were very sick, which I've loved and I've never regretted that. So after my internship, I went up to Boston, where I spent quite a number of years as a resident and a fellow. And I got there, and I had been given the name of a very famous endocrinologist at the Mass General to take care of me. And I called him, and I said, "Hi, I'm Dr. Steve Gabby. I just arrived in Boston. I'm going to be up here at the Lyman Hospital for the next 5 to 7 years. And Dr. So-and-so in New York recommended that I see you for my diabetes." And he said, his exact quote, I've never forgotten, I can hear his words, "Patients with juvenile diabetes are a pain in the ass." And so And so I limit the number in my practice. Now, you're up there at the Lyman Hospital, and Dr. Priscilla White is there, and she takes care of the pregnant women with diabetes. Maybe she'll take care of you. So one day I saw Dr. White. She was a very tiny, gray-haired lady, then 70, and I went up to her, and I told her the same story, and she said, Stephen, and she never called me by anything but my first name. It was interesting. Stephen, I'd be honored to care for you. Please come to my office and let's talk. So Priscilla White, and if I go on to her, I'm going to say shut up. But Priscilla White was really my link with the history of diabetes because she had gone to Wellesley, applied to Harvard Medical School, was not accepted because she was a woman. Applied for residency at Harvard, was not accepted because she was a woman. But when she completed her training, Elliot Joslin realized that she was a very special person, and he hired her in 1922. When was insulin discovered? 1921. Now, Banting, who discovered insulin, only sent insulin to 3 places in the United States. One was the Joslin, the other was to Frederick Allen, who had kept children alive on starvation diets in Morristown, New Jersey. That was the only way you could keep people alive. A diet of 400 or 500 calories a day. And then also to Sansom in Santa Barbara, the Sansom Institute. So Priscilla White was there not when the first injection of insulin was given, but she arrived not long after that. And as the children survived, if you developed diabetes before insulin, you lived about a year and a half. As the children survived, Elliot Joslin and Priscilla realized they needed to do something to support the kids, and they developed the idea of summer camps. So the children could be out in nature and they could be supported by good health care. They are still in existence today, but there's something interesting. They worried about kids with diabetes becoming dramatically involved and having kids and increasing the number of people with diabetes. It was kind of interesting back then. And then as the children survived and the young women survived, they realized that they needed to do something to provide care for pregnant women with diabetes. Before the discovery of insulin, if you were pregnant and you did conceive, and you did, you would die, and your baby would die, because the hormonal changes of pregnancy accelerate the likelihood of diabetic fetus and those will occur. So the advice at that time from the experts in the field was that if a woman with type 1 diabetes, as we call it now, should become pregnant, most of them were infertile because they didn't ovulate because of their metabolic abnormalities, they should have a termination of pregnancy. It was not fair, it was not reasonable for that not to be done because otherwise they would die and of course the baby would die too. And in fact, when Joslin reported his experience to one of the Boston Medical Societies in pregnancy, he had about 7 patients, and all but one of them died, and their babies all died. In fact, there's one very tragic case that he reported where a woman became pregnant, had her pregnancy terminated, became pregnant a second time, had her pregnancy terminated, committed suicide, and her husband lived. I mean, it was a disaster. So Priscilla White developed programs for pregnant women with diabetes. She realized in 1928 that the control of the mother's glucose was directly linked to the outcome of the pregnancy, and how well the baby did. And in fact, the mother's glucose is the baby's glucose. Glucose goes across the placenta, and the baby's level is the same as, a little lower than the mother's. Insulin doesn't cross the placenta. So she was a pioneer in recognizing it. Very true. She also was a pioneer because she realized that one physician could not do everything. She was one of the first people to bring together teams to care for these complex patients. A highly skilled endocrinologist, that was Dr. White. A very experienced obstetrician, that was Luke Gillespie, who was also my mentor, nutritionists, social workers, ophthalmologists for the eye problems, nephrologists for the kidney problems, cardiologists for the heart problems, all of them working together. She dramatically improved the outcomes for these pregnant women. She realized that the longer you had diabetes and the presence of vascular disease worsened the outcome. Encouraged women to have their children early on in life before the complications of diabetes like kidney disease occurred. Tragically, she made one very, very serious mistake, and it was really very sad. She worked with a couple. He was a gynecologist. She was an endocrinologist. In studying the hormonal levels in the urine of pregnant women with diabetes, and they discovered that the women had low levels of estrogen in their urine, and thought that the reason that babies of women with diabetes were so likely to be stillborn, and when I was a resident, it was 15 or 20%. These babies were stillborn. Terrible disaster. The last third of pregnancy. She and the team she worked with thought it was due to this estrogen deficiency. So how would you take care of that? Well, let's give them estrogens. What they didn't realize was that the estrogen deficiency in the urine was a sign of placental insufficiency. Placenta was failing, and that's why the babies died. So they began giving these pregnant women diethylstilbestrol, and you know what happened. When I was a resident in Boston, the group at the Mass General discovered that diethylstilbestrol was a carcinogen, and that women who had been carried in utero and whose moms took diethylstilbestrol had an increased risk for vaginal cancer, as well as other changes in their reproductive systems. So unfortunately, although she did so much great work, what she is remembered for by many is this diethylstilbestrol disaster. And I remember I saw patients with her where she was a great influence on my life and really taught me how to live with diabetes. Someone saying to Dr. White in the clinic, Dr. White, why don't we do a prospective randomized trial to see if diethylstilbestrol really makes a difference? And Dr. White got very angry. She said, let somebody else do that. I know it works. And because she was such a powerful clinician, clinical force, this was adopted all over the country. New York, Boston, Chicago. So it really was a very sad outcome of her efforts to improve the care of women with diabetes. What we've learned is that how well the babies do is directly related to what Dr. White said in 1928, how well the mother's glucose levels are controlled. Now today, we have glucose meters, we have many different types of insulins, we have a much better understanding of the pathophysiology of these problems, we have insulin pumps. And so today, a woman with diabetes, type 1 or type 2, who gets excellent care has nearly the same chance to have a healthy baby as a woman without diabetes. There are some exceptions. Women who have blood vessel disease, it's a greater risk. Women who conceive when they're in poor glucose control can have as high as a 25% chance of having a baby with a major malformation. But the stillbirths are very uncommon, and the patients do very, very well. And pregnancy doesn't shorten the life expectancy as it once did. So I was blessed to work with Dr. White and to learn from her. My interest over the last years has been on the subject that relates to the PIMAs, and that's gestational diabetes. So the hormonal changes of pregnancy represent a stress to the mother's pancreas. They create a state of insulin resistance. And if you're a normal pregnant, and that happens in every pregnancy, And if you're normal, you make more insulin and you are able to adjust to that. If you're normal, your blood glucose levels after a meal still do go up higher than they would when you're not pregnant, but not dangerously high and not a danger to the baby. In fact, having those slightly higher glucose levels after you eat is a benefit because it drives more glucose across to your developing fetus, and glucose is the most important fuel for the baby. But if you have a state of insulin resistance before you conceive, or if you're at greater risk for type 2 diabetes, these hormones that create insulin resistance can lead to what's called gestational diabetes. And that is that in the last third of pregnancy, your glucose levels after you eat, and in some cases, not as common when you're fasting, go to dangerously high levels for the baby. And if the baby gets more glucose sent across the placenta to it, what does it do? It responds by making more insulin. And insulin is the fetal growth hormone. And so it grows bigger, but especially fatter. So we've known forever that the big fat baby, the diabetic, is at greater risk for fetal death. That reflects the mother's glucose control, and at much greater risk for birth trauma. And it's been known for many, many years. And that's why more cesareans are done in these cases. So these high glucose levels go across to the baby makes more insulin, grows to be bigger, and you have the immediate problem of difficult birth for the baby, this big fat baby, and in the more extreme cases, fetal death in utero. For the mother, developing gestational diabetes, and one of my patients said it best, I think, is a sneak peek. It says, I didn't handle this stress well, and I'm more likely to get type 2 diabetes. And in fact, 50% of women who get gestational diabetes will develop type 2 diabetes in the next 5 to 10 years. So what does that mean? That means we have to take action. We need to check the mother's glucose levels after birth. Did she go back to normal or not? And then we have to say, okay, Mrs. Smith, you had gestational diabetes. You have an opportunity to prevent type 2 diabetes from developing or delay its onset by losing weight, exercising, eating a healthy diet, and don't smoke. And so that is really an objective of ours in this high-risk population. Now, we did not for many years appreciate that the in utero environment of the fetus could have lifelong impact. And now there's a well-established scientific field that looks at fetal environmental stresses in utero and disease outcome later in life. And one of the best examples is what happened with diabetes. So women who have gestational diabetes have babies who are much more likely to be obese, and this is generally seen as they get to be adolescents, and much more likely to develop type 2 diabetes. Now you'll say, well, yeah, their mom had type 2 diabetes and there's a powerful genetic risk. These kids develop type 2 diabetes earlier. So what does that say? That says if you control the mother's diabetes well in pregnancy, not only is the fetal outcome and the immediate neonatal outcome going to be better, but you might prevent diabetes from developing in that child and obesity from developing in that child later in life. So that is really, really important. Now, where this has been shown very clearly is in the penis. So what they've shown is that women, female women who don't have diabetes or don't get gestational diabetes, have babies of normal weight who are at no greater risk for diabetes later in life. But female women who have diabetes and female women who get gestational diabetes have babies who are at much greater risk themselves for obesity and diabetes. And the environment, and this is, what you wrote in your paper is so impactful and so important. The environment is what's critical for these people. I mean, how can you say to someone in the inner city, and I'll talk about our own community over at University Hospital East's neighborhood, we have a community hospital in East Hospital East at Broad and Taylor, one of the most depressed areas in our city, an area with the highest mortality for heart disease, diabetes, cancer, and the highest infant mortality. Go visit there. What do you find? You find an area where people don't feel safe going out and exercising, simply walking or jogging or going to a park. They don't have that opportunity. There's a historical film that's been done on that neighborhood, as has been done for other neighborhoods in Columbus. And there was at one time 6 or 7 supermarkets in that Near East Side neighborhood. How many are there now? None. There's not a single supermarket in that neighborhood. There's not a single place where you could go and buy fresh fruits and vegetables or healthy foods. So it's great to say to people, well, we want you to go out and exercise and eat a good diet and have a healthy, well, hold it, I can't do that. It's not safe, there's no place to go, and I don't have the ability to buy healthy food. So we have committed $10 million, that's the University and the Medical Center, in partnership with the City of Columbus, in partnership with the Columbus Metropolitan Housing Association, to create a healthy living environment in the neighborhood around University Hospital East and then beyond. We start with the neighborhood around the hospital and around the ambulatory site that we have there that's devoted to caring for the problems that the neighborhood has, which is heart disease and diabetes and the need for primary care. And we're going to do that by creating a safe neighborhood, a neighborhood where they can exercise, a neighborhood where they can have health education, creating a health education center, and bringing in markets where they can buy healthy foods. We already have our ambulatory site there. We already have farmers markets. We have a big community health day that we provide for screenings for the neighborhood. But we're going to be working there in the years to come to correct these problems and create a healthier neighborhood. Now you might say, isn't that strange? You're actually going to start to do things that are going to increase the health of the neighborhood. And we're doing that all over, so it's not just there, but that's one of our areas of focus. But that'll keep people from getting sick, and that'll keep people from needing to go to the emergency room or needing to go to the hospital. And won't that be dangerous for you in terms of your revenue and your income? Well, we have a bizarre health system in this country that pays us to do more and to do more and more for sick people, and we cannot sustain it. As you well know, 18% of our GDP is healthcare, and it's already banked. Starbucks pays more for healthcare for its employees than they do for coffee. And the cost of healthcare is greater than the cost of the steel that goes into automobiles. So we've got to fix this. We have to fix it. And fortunately, the payers and the Medicaid and Medicare leadership see this, and so we're now in a very dramatic transition phase of saying we're going to pay you for value and quality, and we're going to pay you for keeping people out of hospital. And that's how it should be. Mount Sinai tried to do this in diabetes years ago. They created a series of clinics where they provided all the things I've talked about: healthy nutrition, counseling, preventive screenings to help people with diabetes. They couldn't get paid for it, and they had to close the clinics down. We'll pay you for an amputation or for dialysis, but not for the methods, means that you need to go to keep people healthy. So diabetes is a big part of those healthcare costs. Obesity is a major part of that. environmental factors, diet, nutrition, exercise, socioeconomic and cultural pressures on people, what they see advertised, what they read in newspapers, continue to fuel that fire. There is evidence that some of this is slowing, but not dramatic. And I think you've discussed that beautifully. In this population that, fortunately, is an example of what happens when these environmental factors go wrong.
I just want to say one thing. I really appreciated your comments, Dr. Gaddy. One thing I think that's really important, it's still, there's a number of really good histories on particular aspects of diabetes. Like I'd recommend one book to you by Chris Feudner. I know I was mispronounced his name, but he's a CHOP down in Philadelphia. It's called Bittersweet. He looks at the records of the Bay Street and later Joslin Clinic, and looks at how diabetes, he calls it transmuted disease. He studied with Charles Rosenberg when Charles Rosenberg was at Penn. And what happened is, as patients were living longer, they began to have the complications and the challenges, and certain types of insulins were proven not to be as effective. Some insulins were better with patients than others. And the thing that's really compelling is it's got a very human face to it. But the story of Priscilla White is really an important one because she and Elliot Joslin and Marble and all of the people at the Joslin Clinic helped to pioneer the system by which we use for management. And what you said earlier now is as much as gospel as anything is in biomedicine, which is that control matters. And that was something for a long time wasn't really known. And we also didn't have the technology to do it. So that was, and very often it's like Priscilla White often doesn't get mentioned outside of Elliot Joslin, except for people that know the history of diabetes. And so that's good.
I actually mentored Dr. Foot.
Oh, did you?
When I was at Penn, yeah, and he was working on that book. He started, I think, the first thing he posted was an article.
Yeah.
Yeah, so I know him very well. And it is a very important book because, as you say, when insulin was discovered, people thought, well, there it is. Now we have the cure, and people will live forever with diabetes, or at least they'll live a normal lifespan and do well. There are real challenges with keeping your diabetes well controlled. I can tell you about them. And then, as you pointed out, as the years go by, your likelihood of developing these serious complications, increases. As I said, I've had diabetes 45 years. I'm a real exception because I don't have any complications. And that's pretty unusual. In fact, unfortunately, I visited a patient in the ED today. I delivered her 21 years ago, and she was living with a kidney pancreas transplant. So, she developed those complications and had to have measures, and she had it here, and she's done pretty well, all things considered. I delivered her baby, and her daughter was there. She's going to be a nurse, graduating in May, and is 21. So she's had an amazing life given how sick she was in the pregnancy and soon thereafter as a result of the transplantation. So insulin was certainly a gift. As the other John would say, insulin is your life insurance policy. It's a gift from Banty and his team. But it did prevent lots of other problems from developing. Unfortunately, type 2 diabetes can be very silent. And a third of the people, and I don't know if this is still true, but it was for many years, a third of the people with type 2 diabetes are discovered to have type 2 diabetes when they've already developed eye changes. And you have to have diabetes for about 10 years to get the retinopathy of diabetes. So they go to see their doctor because their vision is blurred. And the doctor looks in their eyes and says, how long have you had diabetes? And they say, I didn't know I had it. Well, you've had it, and you probably had it for a while. And the eyes are a window into the other vascular problems that you might develop. So, as you point out, in the these screening screenings are really important in identifying people early, and that's what gestational diabetes does for us. It gives us that knowledge that these folks are at great risk. And it is true that if we get them to lose weight and exercise and keep good diet, in many cases that type 2 diabetes can be delayed or even prevented.
And thanks too also for the reminder about the gestational diabetes, which didn't include the paper, which is already my sense of making sense of a lot of this complicated material, but a lot of the really good research in the past 30 years after Bennett and his team made their mark. And that's where a lot of the epigenetic questions are beginning to emerge, which you described with, which is really important. Thank you.
And there's a huge controversy today. In fact, there's a meeting at the NIH Monday and Tuesday, Wednesday of next week about how do you define gestational diabetes? What glucose levels in the mother are dangerous for the baby? The original diagnostic standards were based on glucose tolerance tests that were done by a fellow named John O'Sullivan in Boston, and he used the test to predict which women would develop diabetes later in life. And then he and others realized that they did predict women who were more likely to have a big baby or even a stillborn baby. And so for years, the diagnosis was made with an oral glucose tolerance test and seeing how the mother responded to that ingested glucose load. Some years later, the values were adjusted, and today, using the standard diagnostic criteria, about 5 to 7% of women will have gestational diabetes, 5 to 7%. The groups at greatest risk would be Native Americans, African Americans, Asian Americans. They would all be at greater risk for gestational diabetes. So there's that genetic risk as well. And so those women, all women today are screened for gestational diabetes. All women are screened because that's the only way we can detect them and treat them. And generally the treatment is with diet and then following their response to the diet, looking at their glucose levels. Several years ago, a study was done called HAPA, the Hyperglycemia and Pregnancy Outcome Study. A very important study, supported by the NIH. I was part of it. And over 23,000 women around the world underwent glucose tolerance tests. And the results were not made known to their doctor or nurse unless they were so high that it was clear the woman had diabetes. So the idea of the study was, can we see what levels of maternal glucose lead to bad outcomes for the baby and the mother? And the only way we'll do that is by blinding the results and then looking and correlating the outcome of the baby and the outcome of the mother. But what they found was that there was no magical cutoff. So as the mother's glucose level went up, and they measured these generally around 28 weeks of pregnancy, long before the baby was delivered. As the mother's glucose levels went up, the babies got bigger and fatter and had higher insulin levels. Remember I said the babies made more insulin. But there was no point at which you said, uh-oh, if it gets above that, that's the danger point. So what does that mean? That means that whatever you're going to use as a predictor is going to have to be based on a reasonable statistical risk estimate. Okay? So a group of folks came together, the International Association of Diabetes and Pregnancy Study Groups came together and said, let's try to come up with reasonable diagnostic standards for predicting when babies have an odds ratio of 1.75 times greater than normal to be big and fat and have high insulin. We think that's a reasonable risk estimate, risk ratio. And they came up with those glucose levels. Well, those glucose levels would predict that about 18% of women would have gestational diabetes. 18%. What does that mean? Well, folks would say, we can't handle that volume. We don't have the doctors, the nurses, the nutritionists, cost, the concern and stress on the mother, 5 to 7% versus 18%. Should we really do this? Very controversial. To add to the controversy, the American Diabetes Association said, we think this is a pretty good way to diagnose gestational diabetes. And we recommend that these new standards be applied. Now, some people might say, isn't that a little self-serving? Aren't you guys who are endocrinologists going to be involved in caring for those women? The American College of OBGYN said, we don't believe it yet. There's no evidence in a clinical trial that says it's important to treat women at this level. There have been some prospective trials, and they looked at those results, and yeah, there is evidence that it does help, but the American College of OBGYN said, we don't agree with the American Diabetes Association. You have these two major professional organizations who are at conflict. If you're an obstetrician, what do? Well, you're concerned that if you don't use the expanded protocols and something goes wrong, you could get sued. The patient could say, I had a big fat baby. The baby had birth trauma. And didn't you dummies know that you should have used the ADA standards? But the obstetrician says, hold it. My professional organization says I should use the existing standards. So there's going to be a meeting at the NIH to review this controversy and see what the next step should be. I'm not sure what is going to be said. Some believe that the standard should be elevated to an odds ratio of 2-fold greater. And if you do that, you wind up with about 8% of women having gestational diabetes. Now, you may miss some patients, but some people would say that's a pretty reasonable number of patients to treat and a pretty reasonable risk for the baby. Others would say that before we do anything, we need prospective randomized studies where we see what happens when we do and we don't treat patients with these levels of diabetes. Mark Landon, who chairs the OBGYN department here, has done one of the most important prospective randomized trials in gestational diabetes. It's part of the NIH. He'll be there. I have a family emergency, so I can't go. I was hoping to go. But I don't think anything definitive is going to come out of this few-day meeting. I think they'll probably say we need more data, which is just going to leave people wondering, what should I do in my practice? But it's very controversial, as you can.
Well, why don't we open this up, and I have an opening question which I'd like to pursue, there have been references in passing, and I just want to kind of understand where we stand on this. The problem of genetics, genetic susceptibility, lack of genetic susceptibility, environmental causation, the processes, we might have a background of genetics involved. What are the markers? Is that going to work out? And what is the current understanding of a genetic background to diabetes?
Yeah, there are certainly markers. Certainly, family history is the best we have. I mean, you need to do everybody's genotype, figure out what their risks are. If you look at their family history and their mom and dad had type 2 diabetes, the odds are they'll get it. If they have a mother or father alone, they still have a greater risk. So it's that genetic susceptibility, and then it's these environmental factors.
Well, I guess what I'm driving at is I suddenly learned about epigenetics last year, and I was really struck by the Dutch studies, the Dutch family studies, that these women suffered a trauma in the fall of '44 into the spring of '45, and there was this apparently was an outcome of that trauma of starvation that produced generational and transgenerational effects down into at least the grandchildren. And so, are we told we say we take a family history of an individual with diabetes, your father, your grandma, actually my grandmother had diabetes, my father was always wondering, but now I think about it, I forgot about that. But what is it, is there, on a population basis, because I keep thinking about the Indian experience. And I think back to the 1860s and 70s, on the plains, when not huge numbers of people, but numbers of people, survivors of unbelievably violent warfare, are stuck on reservations and given barrels of flour to eat. And they survived off of this flour rations for decades. And they still eat this stuff. My sister lives in New Mexico. The Indian, fried bread is still part of the diet. And it can't be good for anybody to eat that much flour. And particularly if you're coming off of a much more diverse. So the question is it going to be possible to get at the sort of event analysis? I mean, can we talk about historically traumatized populations? Because it sounds like I can't say about Asian Americans, but African Americans and Native Americans are historically traumatized populations. In one case, we're talking 300 or 400 years, and Native Americans, you can give your own numbers on that. But we're talking about real history, and that's where I think we can. There seems to be something of my perspective as a historian thinks of traumatized populations over decades and literally hundreds of years, and the possibility posed by the Dutch, the Finnish, because the Dutch and the Finnish studies of transgenerational impacts of historically traumatic events.
I think that epigenetics opens up, and the question of gestational diabetes in the in utero environment and how that translates to both health for the mother as well as the health of the progeny is one of the ways in which epigenetics specific to diabetes is particularly powerful. The challenge is that historically going back and studying that, the reason why the Dutch studies work the way they do is the Dutch were pretty, OCD when it comes to record keeping.
Pretty much, yeah.
Okay. The challenge is that with Native Americans, yes, there is historical trauma. And if you also believe in, say, for example, work by Bruce McEwen on allostatic load and stressors, hormonal responses, that living under conditions of confinement and stress, that may also be a contributing factor to any number of chronic diseases, or at least weakening of the immune system, susceptibility to infectious and non-infectious diseases. The difficulty is that for all of the great capacity of this federal state to keep good records, records on native populations are spotty until relatively recently. So a lot of the stuff we have about food and diet until pretty recently is uneven and anecdotal. Arlo Shverliska's study in 1908 was fairly comprehensive, but by our standards, it was a pretty weak observational study, and he made all sorts of assumptions based upon that later predicated other scientific research. So it's by way of saying that I think that historians can contribute to that by providing the context and thinking about how larger questions of confinement, of discrimination, of persistent socioeconomic factors, lack of availability for certain foods, the decline in what is known, say, in the British Commonwealth as like country foods, so being able to have subsistence off reservation. All of those things likely and probably did contribute to that. There's a great article by Dr. Bennett, Nutritional Reviews, in which he talks about these environmental changes as being drivers beyond this. But being able to actually document like caloric intake and document actually what they're eating is incredibly difficult. The other thing I'd add real quickly, and this is not so much to gainsay the trend toward genetic explanation, is that there's also one other thing here that's important to keep in mind is that if we start going down the road that you're describing here about systematically traumatized and impoverished and confined populations, it also takes away something very important, which is native agency in the face of these types of diseases. And one thing that's been really important and empowering, both as a reaction to the stigmatization that occurs from all sectors, not just biomedical researchers and clinicians, but also from broader perceptions, but also Native peoples drawing upon the very important and vital work being done by the NIH in conjunction with the Indian Health Service. They're now taking matters a lot in their own hands by discovering native foodways, by going back to an earlier diet that relies on complex carbohydrates, more proteins, and such. And I think that's really important. It's that what I worry about is that it's a very attractive way to sort of have an explanatory narrative that can undercut native agency in responding creatively to any sort of health conditions in Indian country, if that makes sense. Yes?
Yeah, I'm a PhD student at Klingle School of Public Policy, and before that, I'm a long-time Chinese science journalist. So just now, Dr. Klingle, just now you mentioned the New England Journal.
I'm sorry.
Yeah, you maybe this question is also for you.
We'll feel that.
Yeah, so just now you mentioned the New England Journal of Medicine's charts. It's very interesting. It's American diabetes population begin to surge in mid-1990s.
Mhm.
I mean, your paper talk a lot of environmental change contribute to the diabetes, but
Possibly, yeah.
in mid-1990s, most of Americans' social change has long time completed.
Mhm.
I mean, maybe it's in 1960, 1970, but the trend begin to grow dramatically in mid-1990s.
Mhm.
So,
So why does it grow at that point?
I've grown that point, not earlier. And I'm very interested in this question because in China, in 2009, Chinese diabetes population surpassed 100 million. Yeah. Oh, thank you. Yeah. We can explain this quite well with environmental change because in the past 30 years, China experienced tremendous change in lifestyle, environment, nutrition. But America, I mean, is experiencing the changes quite early on.
So what accounts for that uptick? There's a variety of answers. One of the easiest one would probably be you've got increased life expectancy, and the other is improved testing. Okay. So one of the things that Dr. Gabby mentioned, which I think we forget, is the ubiquity of being able to use what grew out of earlier radioimmunoassay technologies that now is you can prick your finger and put it into a one-touch and immediately get a reading. That's relatively recent technology. So there's better testing, plus Americans are living longer. And so particularly in the case of type 2 diabetes, even though it's sliding down the age scale and in part being driven by things like Dr. Gabby talked about with gestational diabetes, and then the in utero effects later affect progeny. But you've got better testing, so that's part of it. Another thing is that Elliot Jocelyn mentioned this as early as his articles in the 1920s, that there's large numbers of people that are undiagnosed. So with this better testing, now if you think about it, there's this reservoir. Okay, imagine you're out on a boat at night and you've got a light, okay? If you've ever been out there, you expand the aperture of the light, so suddenly you're discovering a lot more cases out there. So that's part of another reason why there's the potential uptick. I can't explain necessarily in the Chinese example why that's the case, but I'd suspect there's probably similar drivers going on there as well. I mean, the other thing is to keep in mind, how many people in rural China, for example, are getting regularly tested to find out,
It's very
blood with HbA1c, I mean, any of the other ways that you use to diagnose diabetes, how is it that, in a certain level, as testing improves, you're going to see that, you're just going to be discovering more cases.
Yeah.
So,
But on the other hand, the other argument is, certainly the medical technology is causing more, but it's exposing more background.
Right.
And, but on the other hand, we do have significant environmental risk.
Right.
And an increasingly traumatized population.
Right.
In an era of economic decline. Let's be kind of put our brass tacks on the table here.
Right.
But what the model really is, economic trauma results in conditions that encourage population diabetes.
there's that.
But then it may hit certain populations more strongly than others within those potentially traumatized populations.
And then there's also, if you believe in, I'm convinced by some, but not all of the research, as I'm drinking here out of a plastic bottle, that Bruce Blumberg and others, Bruce Blumberg works, at University of California, Irvine, is that endocrine disruptors may also be another driving factor behind obesity. And Bruce Blumberg and his group coined the term obesogen to describe in particular the way in which these chemicals interfere with the endocrine system of the human body to produce obesity and thereby produce diabetes. So that could be another factor as well. One interesting thing is that there's a wonderful book by Nancy Langston, who is the outgoing editor of the Journal of Environmental History called Toxic Bodies, about DES. And it was wonderful to be reminded of Dr. Gabby about Priscilla White's unfortunate involvement with DES and hormone, using DES as a way of preventing complications of pregnancy, is that when the FDA was basically given expanded regulatory and research powers in the 1930s and the New Deal, that DES and basically using estrogenic hormones both to improve human health as well as to boost weight gain in livestock and poultry production. It was brought before the FDA. Has anyone in here read Toxic Bodies by Nancy Langston? Okay, you should read it. It's really a wonderful book, okay? What she says is they went before the FDA, and several of the FDA scientists said, we don't know enough about these chemicals in order to move forward with authorizing them for medical use, let alone, for industrial agricultural, let alone medical use. But the FDA decided under industry pressure to go ahead, okay? One of the potential estrogenic compounds that we're looking at is related chemically to BPA. So the thing is that there's been a lot of science for some time that suggests that these hormone disrupting chemicals were long known to have their effect. And if you want to think about it, and again, Nancy can only make assertions and correlation. There's not direct causation because the evidence isn't there. But if you want to think about the uptick as well, is that the advent of plasticizers, the advent of any number of a variety of chemicals that many researchers are targeting as endocrine disruptors and therefore implicating as obesogens or diabetogens, that uptick beginning in the 70s and 80s and 90s and moving upward is with the ubiquity of a lot of these chemicals in our environment, from PCBs to herbicides to plasticizers like BPA. So that's another thing as well. And then there's the added question, to what degree are certain communities more at risk for consuming these chemicals than others, either because of proximity to particular sites where these chemicals are, these exogenous chemicals are in great supply and therefore in the human body, or through consuming particular types of food. And if you want to get back to the educational component, socioeconomic component, your upscale urban parent driving a Volvo festooned with stickers from elite schools will likely know better to feed their kids certain types of food, whereas your family, and I'm generalizing, but I think for the sake of argument I'm not, the family living in, say, South Side Chicago may not. And so there's that question of background exposure as well, which also feeds into the economic conditions.
Yeah. Even if, and this sort of gets, I've kind of thought about John's question. I mean, even if they know better, even if both families know better, there are differing levels of dependence on institutional sources for food.
Yes.
And so the number of meals your kid gets from a school cafeteria, for example. And I think one of the things that John was bringing up is, what's, partly because we're sort of obsessed with, what's the moment at which all you have is original sin in terms of a health outcome, right? And so, genetics was going to provide that explanation, and then epigenetics deeply complicates it and brings into it the intergenerational transmission of context as well as of data.
Yeah.
But now I'm thinking about where does your food come from and the sort of degree of choice parents have. And one of the things that's happened that's very contemporary is food prices are going up. And if a lot of your food comes from charitable sources, so in a recession that's really hit Americans who are kind of marginal, you start hitting food pantries and demand goes up.
Yeah.
And it turns out that food pantries get their food where they can, and supply chains have gotten much tighter, and we're not at just-in-time delivery for food, but food surpluses have gone way down because the logistics have been transformed over the past 20 years, which means that food surpluses that could go to food pantries are things that are sort of less consequential for suppliers. So the things that were high-ticket items, where you could just have a big surplus of them, because what are you going to do? Those things have dried up, and what's left over is a lot of bread. And as food prices have gone up and institutional funding has gone down, at least in Columbus, the composition of food, of the bundle of food provided, has shifted away from meats, has shifted away from nutritionally dense foods, and you can walk out with a shopping, in either you get a box or you have a choice model. But in both cases, the proportion of breads has gone way up because that's a staple that hasn't changed and proportionally is overrepresented. The other thing that's gone up, because in part because of the sort of fashion, because the sort of local ag is very much in vogue right now, there have been new institutional pathways to deliver a lot of fresh veg to food pantries. And people say, I don't know what the hell, I don't know what to do with this. Or it comes, if anybody's ever belonged to a CSA, you get, it's like this week you just get, you get 10 pounds of rutabagas.
Or kale.
Or kale. And you have to, what the hell do I, so you have this sort of bizarre combination of feast or famine.
Yep.
And so here's a model where you're being handed fresh vegetables. So if you observe that, sort of as an outsider observing, it's look, you're being given these fresh vegetables for free. What's your problem? And the fact is, it doesn't come with sort of basic infrastructure like pots and pans and cookbooks.
Yeah.
And it also spoils fast, and patterns of time use are really different. But it's really kids' institutional dependence that I think on, for meals that makes even the interventions that Dr. Gabby's talking about really difficult.
Yeah.
Because, it's great that you've got a supermarket, but, rational households that are on the free lunch side of the free lunch divide, your kid, that's taken care of. And it's not just the purchase of raw materials, it's also the time involved in preparation and a set of cultural things kids are going through about conformity in who eats what.
Yeah.
And sort of surveillance and control of that are so difficult that it makes me wonder about an intervention that's about ambulatory center and putting fresh markets in.
No, and all those points Colin are taken well. And one thing I would add, it was in the background while I was going through my slides this morning, but they were interviewing someone who's an economist, I think either NC State or Chapel Hill, talking about, and there's still not nearly enough research done on this, which is that we know that subsidization of particular sectors of American agriculture is very much responsible for the food system we have today. But that subsidization of the American agricultural food system really subsidized, for example, the delivery of carbohydrates, particularly breads, grains, stuff like that, or meat, but not so much fruits and vegetables, okay? And so that's something, and so it's not unsurprising that a lot of those foods not only get shunted in the school lunch program, and there's now a number of good studies, I think it's Deborah Levine, Lunch for All, or something like that. There's a couple of new books that just came out on school lunches. And then the other place they get shunted to is a very variety of welfare programs, including, for example, the BIA providing commodity foodstuffs for Native peoples across the country. One only needs to read any number of stories by any number of talented and wonderful, amazing Native authors from Louis Erbich to Sherman Alexie to realize that commodity cheese is constantly reviled and joked about, yet an important part of Native life across Indian country. Okay, so I think you're absolutely right on that. The other is that you're also, and I joked about kale because I remember in our CSO we got kale for this first time. I'm like, what's kale? And that lack of knowledge, I think, is really important as well. So there's this question of food waste and this like separation of the knowledge from that. So yeah, no, those are both great points. One thing that I mentioned to the group of students that I met today and had a wonderful discussion with them is that one of the parts, the next part of the research I'm going to is George McGovern held hearings in the 1970s on nutrition, particularly targeting sugar. I mean, Robert Lustig, is right now one of the big scientists really talking about sugar as a toxicant. But the debate over sugar is very long-standing and goes back centuries. But McGovern held hearings on sugar. And what's very curious is that Dr. West, who's desperately scrambling for funding, this is Kelly West, University of Oklahoma, because he wanted to do, unlike the NIH study, a multi-site comparative study of diabetes epidemiology among a variety of Native peoples. The NIH, he finally got a grant and he died the next year while traveling in China. But when trying to scramble for funding, he went to the International Sugar Research Foundation. And what's very clear is the sugar lobbying group was working very hard to sort of push back against McGovern. So McGovern creates holds these hearings that yield eventually our food pyramid,
But McGovern also was a senator from what state?
South Dakota.
Right. And he also was a proponent of agricultural subsidies. So it's in this way, going back to your argument of original sin, is that he stands very much as this complicated figure, both promoting agricultural subsidies, but at the same time realizing that there are very real problems that needed to be addressed regarding nutrition. So it's a good point. Other comments or questions? Paul, right?
Yeah, so related to this trend that had been pointed out, right, does that have any correlation with increased use of fructose maybe over other types of sugar?
That's another argument that's being brought up as well, is what to do with America's corn
Because that was
surplus.
a blind spot in the study that you mentioned that came out, less than 24 hours ago or just the other day. Was they weren't able to draw any correlation, or they weren't able to look at different kinds of sugars. They were able to
Right.
do a lot of things, but not actually look at fructose versus different kinds of sugars.
And why is that? I mean, what's done with a lot of high fructose corn syrup? It gets put in such a way that it's hard to separate it out. The research on whether or not high fructose corn syrup is to blame in part or in whole for America's obesity epidemic and consequent diabetes epidemic, particularly type 2, remains very much contested. There are many researchers that are very passionately and strongly believe that. There are others that say the way the body metabolizes is not necessarily a difference. The science is very much in flux. So I think you could look at that same graph and you could either say, yes, it correlates perhaps with the increased rise of what to do with America's corn surplus. You could also say that there's a lot of confounding factors that go into that may or may not explain that. What's interesting for me as a historian is the way in which high fructose corn syrup has become the bête noire for many food activists and health activists. I mean, you only need to read Michael Pollan's book. I mean, the most powerful parts of that book are where he's talking about corn. The less powerful is when he's having his midlife crisis and decides he wants to go hunting for wild boar in British County. It's a great book, but my students read that part of it and it's just like, what's he doing? Finding his, inner, hunter. But and then the whole documentary King Corn. So to me, that's interesting. It's like trying to find an explanation that we can all lay the blame at high fructose corn syrup for driving all of that. So, hi, tell me, Dan, right?
Yeah, Dan.
I'm just gonna call someone Dan in this audience. I'll know what you do. I've met a lot of Dans on this trip. I was joking with Dan. So.
How does diabetes, what are patterns, like the global patterns? Does it follow where corn syrup is exported to, or is it like a chronic disease that emerges in like the second world or the global south? Or
It's, tracking it, okay. One of the things that's becoming apparent now, what is your name, sir? Hyo-hang? Okay. Countries that are rapidly modernizing are beginning to see increasing prevalence as well as incidence of type 2 diabetes, okay? There's also, so that's one thing. So, the BRIC countries, for example, Brazil, India, Russia, China, you're beginning to see that, okay? That's often pointed to those people that believe in, James Neal in amended version, so-called thrifty genotype hypothesis, that it is that, evolutionarily speaking, human beings evolved in such a way that we had, limitations on caloric intake, and now we're stuffing ourselves with too much calories, and this is going to be the result. But there's also other interesting studies that emerged out of work done by Ian Pryor at in Wellington, New Zealand, migrant studies. He, for example, looked at Pacific Islanders on the territory of Tokelau, I think I'm pronouncing it correctly, that emigrated from Tokelau to New Zealand and started consuming a Western diet. Then you began to see a rise in chronic disease. So one of the things that's been interesting now is there's been a variety of states, like for example, South Asians moving from South India, Sri Lanka to New York, and you're able to see where they did not have that over a couple generations, the migrant effect. Stuart Wolf was another, actually was a colleague of Kelly West at University of Oklahoma Sciences, better known for giving us the research that now we call a type A personality with risk for cardiovascular disease. There's also that migrant effect. So one of the things is that strongly suggests that there are environmental factors that may or may not be working in conjunction with population questions on genetics that explain the rise in type 2 diabetes. So that's where, but this argument that diabetes is a disease of civilization goes back a century. And it was essentially physicians in late 19th century that were already saying that too much sugar, too too much fat, not enough exercise, that's what's accounting for all of this. So does that answer it?
Yeah, what in Brazil and in China is the incidence rates higher in the historically traumatized, like, as with the people?
That I don't know. That I don't know. That's a good question.
There's another variable that I want, that I've seen in some literature that dates back to the early 90s, that there's a connection between diabetes resistance and lactose tolerance. And so I wonder whether that, so have you seen anything about that at all?
That I don't know.
Because all these populations that we talk about, I mean, we're calling them traumatized populations, migratory populations, they are populations that are not exposed to lactose.
That I don't know, but there are populations that did grow up, for example, consuming dairy products, and diabetes prevalence and incidence rates are going up among those as well. But I don't know enough about the connections with lactose intolerance.
Yeah. But it just seems like it's something that was out there and it disappeared, and I keep wondering whether these audience.
I mean, one of the fascinating things is that going down, thinking about questions of diabetes, is a lot of what we understand now as the modern landscape of biomedical research and its application in the clinic has grown out of a long history of diabetes. For example, the UGDP, okay, you know what that was? That's basically the huge trial that tested oral hypoglycemics. That was the first, randomized clinical trial, and it was not a universal success. There was a lot of controversy coming out of it as a result of whether or not tobulamide, known by trademark name Ornase, there was a higher possibility of cardiovascular and other complications of being on oral hypoglycemics, and it collapsed into controversy. There's a very good book about it by Jeremy Green, who's a physician and historian of medicine, previously at Harvard, now moved to Johns Hopkins. And so what we've learned about that today basically is the basis for now how we can conduct better randomized clinical trials. Insulin, for example, one of the most amazing drugs, in the history of modern humankind. It's one of two major drugs that didn't go through a clinical trial. What's the other one? Penicillin. Okay, and so, I mean, insulin, basically, Banting and Best and Koslov and McLeod were working with pancreatized dogs up in Toronto, figured out how it worked, started using it, and then whoa, and the next thing you know, it's being shipped worldwide. There were a lot of, the history of insulin, Michael Bliss's book, The Discovery of Insulin, it's a very dense book, it's wonderfully written, I really recommend it, and he talks about a lot of the complications of it. So, I mean, I just bring that up, but one of the things that was really interesting listening to Dr. Gabby here is that so much of the stuff that we now take for granted with modern biomedicine, diabetes is intimately involved with that history in a way that's been pretty remarkable. The other thing to bring up, John, this maybe starts back to your question, is that we were talking a little bit in discussion when we came back from stepping out, is that the role of the state in defining and shaping biomedical research agendas, and defining and shaping how to treat and address disease, and also for setting the terms in which certain diseases emerge and are understood. And this came up, and I was reflecting on this, in that the case of Native Americans and questions of diabetes, and I was trying to get to that when I was talking about the frontier metaphor in the NIH publication, Pathfinders for Health, is that the whole reason that the PIMA were, in the minds of the NIH researchers, the quote-unquote ideal group to study, was because of their relationship to the federal government as a sovereign Indian nation. And that in some ways that shaped a lot of and made it possible for the NIH to go in. It also meant that Native peoples not to discount the very important ongoing ethical complications of research within and among Native communities. They were afforded protections that other groups, prior to the adoption of the Belmont principles and the creation of institutional review boards to ensure patient and subject safety, they have built in protection they didn't have, say, versus, say, African Americans with the infamous Tuskegee study. And that's something where I'm curious, for those of you out here that know the history of medicine, it seems like there's not nearly enough attention to the question of political economy and the role of the state in studying health and disease. I mean, is that a fair assessment? I mean, Nancy Langston's book talks about it a little bit, Chris, with FDA.
Right.
But there's not there's not nearly enough about questions of the state formation, the state capacity, and political economy. Is that fair? I mean, for those of you, I see a few heads
I don't
now.
want to make any kind of sweeping statement. John, what do you think? Do you want to make
I don't know, I'm just curious.
You and I would disagree, don't worry.
We would
Well-
I think there's a decent literature on public health in the state.
That's true.
But
But I'm thinking about biomedical,
that's
more
a
the basic
different question
research.
entirely, and
Yeah.
so, I think.
Well, actually, some of our man's research is on the role of the state and philanthropy and biomedical research in the citizens.
Okay.
I mean, it's not out yet, it's a dissertation, called me a dissertation that's being written here. So, yeah, I mean, I thought it was straight to public health, and straight up to low in public
Right.
health.
But I'm thinking that the basic biomedical research, so I'd be curious to read that.
Well, I think it is roughly 4:30. Do we have a question or two to close things off? Yes, Chris?
I have one, John has one.
Okay, well, fire away, yeah.
Actually, I've just got a really, really general question. It seems that a kind of recurring theme in these seminars, which is predictable given the topic of these seminars, is the inseparability of environment from our historical narratives of disease. There was a moment perhaps when a purely biological or as a bacteriological model was apposite, the late 19th century. Linda Nash's book keeps sort of popping up here. And it does seem that your work is really, sort of furthering this study of this sort of deep interrelation between the kinds of epidemiological, nutritional transitions that we've gone through and are going through globally, and the emergence of or perpetuation of or salience of particular types of disease. I wonder if you could just sort of comment on how you situate your work in the broader history of disease and medicine and this question of environment and its place.
Okay.
And perhaps whether ultimately this environment versus, disease agents thing is a completely redundant polarity these days, and models should be much more complex.
I agree with that latter point. I'm still grappling toward that and to work backwards from that.
Right.
One of the things I think that's interesting is that a lot of the research that's been done on the interconnection between environmental history and history of medicine still largely focuses on infectious disease, or it focuses on toxicants, so toxic environments. So for example, with Linda's book, looking at the Central Valley, she begins with questions of infectious disease and the transformations of California's Central Valley that yielded malarial landscapes, and then how it is that early settler colonialists from the United States, America dealt with that. And then we move, bless you, into the modern day with Chicano farm workers and the question of the permeability of human bodies with exogenous pesticides and herbicides in California's industrialized agricultural landscape. Chronic diseases, both within environmental history, but also in history of medicine, have not necessarily received nearly as much attention. And to me, they're interesting, and this is why I kind of gravitated toward diabetes, is that they're interesting because, first of all, the hallmark of chronic diseases, to go back to what has now become a contestable, well-worn metaphor, is that they're part of the so-called epidemiological transition. That we don't see the rise of chronic diseases until we've relatively speaking, vanquished infectious disease, or at least kept them at bay. And that the whole idea of the epidemiological transition has been deeply contested because it doesn't necessarily apply to the developing world. It doesn't even necessarily apply to those places in the United States, like Native American reservations, that remain persistently underdeveloped. But it's that chronic disease is the hallmark of modernity, and thus they are a reflection of our somehow deranged relationship with an ideal environment that I think makes them particularly interesting. And I think that also that it really complicates the environment as an agent of disease. So that's like, I take your point as getting redundant, but trying to sort of tease out, you can follow a pathway for something like exposure to parathion, for example, to go back to Linda's book. But thinking about the multiple pathways that lead to, diabetes, it really kind of, the difficulty for me is sort of to what point is everything environment? It's kind of like Lauryn Hill singing "Everything is Everything," and I don't necessarily want to, with all due respect to Lauryn Hill and the Fugees, I don't necessarily want to go down that path. But it also creates a lot of potential, it's interesting for me to sort of think about that. And I think finally that one of the things that's been interesting, and this is, I found this particular discussion with the group today about Charles Rosenberg's epilogue to the Errors, Waters, and Places special issue of the Bowdoin History of Medicine this past winter, is that I think that there's a profitable reading and cross-pollination, for lack of a better metaphor, between history of medicine and history of science, technology, and medicine more broadly, and environmental history that can yield some interesting syntheses. But I think that chronic diseases in part really, they raise some interesting questions. I mean, one thing is for a while I was considering cardiovascular disease, because that's another one that also has oscillated around a lot of environmental factors. One only needs to look at Stuart Wolf's classic studies of Rosito and Bangor, Pennsylvania, with these Italians that come over and their deep social networks and drinking wine, and how is it that they're able to resist heart disease. I mean, that's another really fascinating study too. So I hope that partially answers your question. So,
John?
John has a question.
and
I
you,
was going to make a comment.
Sure, yeah.
I liked another aspect of the paper, which had to do with the change over time, the historical aspect of what is the environment.
Yeah.
Because you have many things feeding in here. From the progressive era, we talk about the environment as a social environment.
Yeah.
And then we talk about, well, poverty causes disease.
Yeah.
Anybody who looked at TV knew that.
Yeah.
And so you have this part of it, and then you have people who are talking about the actual environment. It's really after you get radiation in after World War II that you begin to get fear of asymptomatic diseases, which is, of course, diabetes, early diabetes, writ large, but many other asymptomatic diseases suddenly become part of the environment. It used to be that you had your home and the environment was out there.
Right.
And what you see is intellectually people begin to think the environment is everywhere, and then there are these crazy people who say interpersonal relations are environment. Not only the food you eat, but interpersonal relations. So the idea of the way people could conceive of the environment changes just over the 20th century. You can see the change, and you can see how even in the history you have, where people are starting out small, and then it becomes bigger and bigger and bigger. And I thank you for that.
well, and I thank you for reminding me of that, because I'm still struggling trying to think about those contextual and contingent and shifting definitions of the environment. And one thing that's been helpful for me, and I mentioned this again in a wonderful discussion I had earlier this afternoon with folks, is that there's not a lot of good histories of epidemiology, but two that I found out that were very useful were Merlin Susser's Eras of Epidemiology and then Nancy Krieger's Epidemiology and the People's Health. What's very interesting is that epidemiologists wrestle with this as well. And today now, social epidemiology, to kind of go back to teasing Warren Hill again, everything is everything. And the real power of socioepidemiology in its many manifestations is to have this expanded view of the environment. But then how and to what degree, what parts of that environment are responsible for particular, etiology and pathogenesis of disease is really complicated. Yeah, but thank you. Thank you so much. This was this is absolutely wonderful
Let's put our hands
time.
together.
And I really appreciate it, and I'm going to go back and tell my friends at Michigan they don't know what they're went to Michigan, they don't know what they're missing in Columbus.
Well, we all.